Hello, my name is Tim Finnegan, and I'm a PGY5 General Surgery resident at Memorial University Medical Center in Savannah, Georgia. Thank you for the opportunity to present our research entitled Random Forest Modeling Using Socioeconomic Distress Predicts Hernia Repair Approach. I have no disclosures. Hernia repair in the US is estimated to cost over $48 million annually with over 1 million cases per year. Despite being one of the most common ambulatory procedures, there is significant controversy regarding optimal surgical approach. For example, laparoscopy is believed to offer faster recovery and fewer wound complications compared to open repair, but hernia recurrence rates are equivalent between the two techniques. The debate became more complex with the addition of robotic hernia repair. Robotic surgeries in the US have increased more than threefold in the last decade, and hernia repair is the most common robotic general surgery procedure being performed. However, a recent multi-center prospective randomized trial directly comparing robotic and laparoscopic inguinal hernia repair showed no clinical advantage over laparoscopy and demonstrated significantly increased cost, increased operative time, and no ergonomic advantage. So with three similarly effective approaches to hernia repair, one would think the patient would have multiple options. But with the evolution in physician and hospital reimbursement policies and enthusiasm towards new technology, we believe there is opportunity for significant bias in hernia approach based on non-clinical factors. So we hypothesized that in patients undergoing abdominal wall herniorrhaphy, there would be socioeconomic variation between the robotic, laparoscopic, and open approaches. We performed a retrospective review of all patients undergoing abdominal wall herniorrhaphy at our tertiary center from 2013 to 2019. Hernia types included groin, umbilical, or ventral. All surgeons were credentialed in laparoscopy and robotic surgery. Patient demographics, ASA class, BMI, insurance type, and hernia details were abstracted for each individual. Patients were then stratified by approach, laparoscopic, open, and robotic. Using the patient's home zip code, we obtained a distress communities index from indicators extracted from the US Census Bureau's American Community Survey 5-year estimates and business patterns dataset. Each metric is weighted equally and standardized to yield a composite distress communities index score with larger values representing worst socioeconomic status. From the EIG website, we also obtained the minority share for each zip code, which represented the percentage of all races and ethnicities except non-Hispanic whites. For our statistical analysis, we employed a machine learning ensemble method known as random forest to classify our herniorrhaphy approach based on our socioeconomic variables. This is a powerful machine learning algorithm that teaches itself the relationship between input variables and the desired classification outcome. The algorithm generates thousands of decision trees from a random subset of variables, which is the forest, and the decision trees are aggregated into a model that represents the average of the decision trees. So the power lies in the use of thousands of models, not just one, to produce a stable, accurate, and less biased predictive model. In developing our random forest model, the demographic and socioeconomic parameters were our input variables, and our classifiers, or our outcomes, were our three hernia approaches. After creating the model, we determined which factors had the largest variable importance when predicting repair type. The larger the variable importance percentage, the more important the variable is in the predictive model. There were 559 patients who underwent abdominal wall herniorrhaphy. 39.7% were laparoscopic, 33.3% were open, and 27% were robotic. There was no difference in median age or BMI between the groups. However, ASA class was highest in the open hernia repair group. More patients in the robotic group had bilateral hernias compared to lapar open. Looking at socioeconomic parameters stratified by hernia approach, overall distress communities index increased from robotic to laparoscopic to open hernia repair. The same trend was identified for rates of lack of high school diploma, poverty, and unemployment. In contrast, median income and job growth significantly decreased from robotic to laparoscopic to open approach. Our analysis of hernia approach stratified by insurance status showed the laparoscopic hernia group had a larger proportion of privately insured or Medicare patients compared to Medicaid or uninsured individuals. Patients in the open hernia group are more likely to have Medicaid or be uninsured than have private insurance. Significant variables listed on the x-axis of the graph were entered into our random forest model. This figure demonstrates the variable importance percentage for each factor entered into our model, stratified by hernia approach. The most important variables with the largest variable importance for predicting approach were job growth for robotic hernia repair, insurance type for laparoscopic, and lack of high school diploma for open. This graph demonstrates that our random forest model had good predictive accuracy for classifying each herniorrhaphy approach with an area under the curve above 0.8 for all models. So significant socioeconomic variation exists in patients receiving laparoscopic, open, and robotic repair of abdominal hernias. We observed that job growth was the most influential factor in predicting robotic approach. Not surprisingly, we noted higher median income ratios in the robotic hernia group, a finding consistent with previous research. Objectively, robotic surgery costs more due to acquisition costs, system maintenance, and longer operative times. Although hospitals absorb the brunt of these costs, patients often must pay higher premiums for this type of procedure, which confines access to wealthier individuals. We also found that privately insured patients were more likely to receive laparoscopic hernia repair, and that insurance type was the most important variable for modeling laparoscopic approach. Despite similar overall rates of laparoscopic and open repairs in our study, more than 50% of patients with Medicaid or no insurance still underwent open repair. There were significantly lower median income ratios amongst patients in the open hernia group. And unfortunately, due to a myriad of factors, including cost of transportation, potential lost wages, and the inability to take time off work, many low-income and uninsured patients tend to present further along in their surgical disease process. The same obstacles also preclude access to preventive healthcare, and this may explain why this group had the highest median ASA class. Finally, our study showed that low educational attainment or lacking a high school diploma was highest among patients in the open hernia group. Health literacy, which directly correlates with higher educational attainment, is the ability to perform basic reading and numerical tasks in the healthcare setting. Often regarded as a major driving factor for healthcare disparity, health literacy is also linked to effective communication between surgeons and patients. Low educational attainment does not imply diminished capacity, but it can prevent a lucid understanding of all surgical options discussed during a hernia consultation. This study had several limitations. The data was retrospective and from a single institution, which limits its generalizability. We were unable to account for individual surgeon or patient preference in their hernia approach. Our hospital is designated a safety net hospital, which may have introduced some selection bias. And lastly, reimbursement for minimally invasive techniques like robotics or laparoscopy is not always guaranteed with public insurance, which could explain why Medicaid patients receive fewer open operations. So variation in insurance type, job opportunities, and educational attainment not only appear to influence surgical approach, but also illuminate inequalities in care. Future investigations are needed to determine if these variables also impact outcomes among the three types of hernia repair approaches. Moving forward, clinicians should strive to ensure parity in the delivery of surgical services to help alleviate healthcare disparities in patients with abdominal wall hernias. Thank you.